Okay, good morning. I'm Bawani. I've been with you since yesterday. I just want to share with you about complementary medicine management of muscle bone health by part of Ayurveda. I'm a registered complementary medicine practitioner with the local Ministry of Health. And the past video, 2 videos and 1 live lecture, you have been given a very thorough introduction to the definitions, classifications, medications, types of risk categories of osteoporosis sarcopenia, which generally affects sarcopenia, basically mass, function, right? As well as the diagnostic ability for you to find out the different conditions are all very clinical and technical. So you being the conventional medicine practitioner, you would be able to gist that out. But what I'm here to share with you today is the perspective of complementary medicine, of what we get after you see them, right? Which means this group of patients, they come out because they go through a specific set of decisions made by conventional medicine protocols. And after some time, they feel that probably the speed of the outcome they wish to see in terms of well-being onto their physique and their fitness needs more intervention. So they come out looking for people like complementary medicine, European wellness, right? Because we offer integrated solution. And to a certain extent, we spend the time that allows us to give personalized attention to them and so on and so forth. So this is where the complementary medicine mix up with the terminology of alternative medicine. And then we have the traditional medicines like the Chinese medicine, the Indian medicine, and we also have now developing the Malay medicine, or also known as the Islamic medicine. So these para chapters are all evolving because locally, I would like to point geolocation of Malaysia. So if you see, we have a division or a council which is dedicated to traditional and complementary medicine. So it's roofed under one component. But complementary medicine on its own, it's so broad that when you come down to today's specification of osteoporosis and sarcopenia, it overall goes back to the alarming statistics that should demand our concern, or probably allow us to be more inclusive in our dialogues with our patients. So once they go to the conventional medicine practitioner and they give themselves a specific duration of time, or if they do have the financial capacity, because most of these treatments are not insurance covered, so they would then go for complementary, alternative, integrative, regenerative, and ABCD medicine. So this is where you probably are part of both the conventional medicine, which we saw, as well as the regenerative, integrative, and complementary medicine solutions. Now, to what extent do you have the integrative medicine solution or the complementary medicine solution is something that you would know, because you are the one pursuing the pursuit of whether you are being able to offer the measures, whether you have the accessibility to the protocol and the products, right? And then it comes down to your demography of patients. So to what extent do we see sarcopenia and osteoporosis when they come over to us is, number one, we've got different category of patients. We've got the B40, right? And then we've got the middle income group, and then we have the higher income group. So the patients who come from these 3 different groups seek for very different solutions. So if I do go back to our patients who come from the B40 category, B40 to the non-Malaysians, B40 is the lower income group, right, in Malaysia. So we've got the T20, M40, and B40. So T20 is the higher earning income group, and then we've got the medium income group, M40, and then we've got the B40, the lower earning group. So they go to different facilities of conventional medicine to present their first range of complaint. And if we look at the Malaysian statistics, you'll be able to see that we've got obesity in the rise, So with obesity in the rise, it's also reversing, it's a backward in terms of the age group. So the younger have rapidly expanded their capacity to become obese. So this has directly contributed to the ability to manage diabetes, metabolic syndrome, and various other underlying conditions, which then becomes grouped in your medical practice as chronic non-communicable diseases. So this is getting younger by population. So if you're a GP, or if you are attending both government locum, or you have your private hospitals locum, and then you also have your GP practice, then when you're attending these 3 stations, as far as Malaysian practice is concerned, you are going to meet this 3 group. So the B40 will come to you with issues where your communication to them, if it just ends with prescription, then the efficiency of them actually recovering or improving from that condition, be it osteoporosis or sarcopenia, will be very low. Because number one, the way you prescribe is rigid and it will be intermittent. It will require follow-ups, which will then be accessorized with multiple diagnostic measures for you to assess the efficacy of the plan that you're deploying on them. So efficacy rate, Malaysian data, is low. This is B40, yeah, the lower income group, which is concerning because they are not just the lower income group, they will also be going to the conventional medicine because you are the predominant solution provider as far as health is concerned. They are not the ones who are going to easily replace you with an AI, right? It's still going to take time. But they are also going down the scale with CNCDs, right? With the chronic non-communicable disease. So they are going to be in that cycle for a long period of time. So if you catch them at a younger age, the chances of you grooming them is higher. So all that boils down to what I'm about to share today. Next, please. I forgot, I don't have that thing. Yeah, thanks. So this is what we came up with when we had a discussion with, there are very few of us who are MDs or MBBS, and we also have gone into complementary medicine and are registered with DNCM. So when we get together, we actually have this group called the industry experts. We contribute towards the framework for education, where they're trying to design different training protocols, and they're also trying to evaluate and suggest content review and analysis to the Ministry of Higher Education, because we are slowly developing our own bachelor programs in this field. Now, the first, I probably should have mentioned this when I started, is that traditional medicine is not massage. So if most of your patients are coming to you and say, I've gone for this massage and gone for that massage, that in no way encapsulates traditional medicine or complementary medicine. So the need to talk them out of it, or the need to be able to manage their consistency or frequency in attending and receiving those different massage treatments they call it, right? It should just end with the word massage. So it's not a treatment. It's a massage, and it's a response or a physical desperation towards pain management. So psychologically, the ultimate goal or the outcome they wish to achieve is to surrender the physical body, which is connecting them to their brain, which is consistently giving them the signal of pain, which is very common in osteoarthritis as well as sarcopenia. It's just that the interpretation of the pain is what they can do to the point of what you are going to reflect on them. They come to you and they tell you, here pain, there pain. And then you tell them a whole lot of jargons. And then what they do, they're like, oh, what should I take so this pain will stop? Then we start off with painkillers, right? So the pain killing management, or the different blocks that we use to manage their pain, will only take them to a cycle where, is that some digital device sound in between? No? Yeah? Can that be switched off? So when we look at the cyclic pattern, what we saw was when they go to the conventional medicine, they get the very first pain management solutions or proposals, and then they start consuming it, and then they go into a cycle with no other changes to their lifestyle. because that conversation didn't take place. That conversation that, you take this is twice a day, and you take this after your meal, and then I see you again 2 weeks later. Maybe they come, maybe they don't come. And then they move on to even see nowadays in Malaysia. So this data that I'll quickly flip through, you can have the slides later. And the QR code you could also scan. Most of my references are made from those articles and publications, which are also cited contents, all Malaysian statistics. So when you ask them, what do you do after that? Do you go back to your doctor after 2 weeks? No, I go to the pharmacy, I show what the doctor gave me, I buy, and I continue popping. So the replacement comes because there's access to pharmacy, which reduces the queue to come and meet the physician, and then they go on a cycle of consuming it until it no longer serves the purpose of managing the pain. It's either the pain has superseded because the underlying condition has gone beyond management, or they have just, developed a resistance to it, the specific medication or whatsoever. And in the same time, a question that they wouldn't have been probed, they possibly could be having multiple other medications that they're popping because they've got other underlying conditions. And all this, I don't know whether you've heard this story. I saw this, it's so cliche, it's a Dr. House, but after watching it, I watched it throughout my pregnancy with my first son. And after he was born, within 2 years, I conceived the second one. And while we were managing the second one, he did exactly what took place in that Dr. House episode that I saw years ago. So a boy was playing with lots of toys, and he suddenly put something into his nose, which got stuck. Then he sent a band of firefighter, I think, small firefighter toy. He sent inside so that hoping the firefighter will be able to fight with the object and bring it out. Then that got stuck too. Then he panicked, he started screaming, and then there was so many other signs and symptoms that alarmed the parents, and then he was rushed. And then finally they picked it out, and then they realized that it's not done yet because the firefighter came out. But what the firefighter went to take out didn't come out. So as usual, House, he solves everything. So he comes and then he picks it up. The same thing this guy did. He took a crayon, popped it in, and then he took another, it's a different doll. It's a soldier, I think. The little miniature toys that we have. So he was digging with it, then he said, itchy, mommy, itchy. I carried him, I went to the ER. The medical assistant, the MA, is the one who saved him with a paperclip in Queen Elizabeth Hospital. So this was year 2011. So why I'm saying this is because people, grown-ups, also do that. There are other underlying conditions. The physician did not have that conversation to address that, but they were, as usual, conventional medicine giving the symptomatic treatment to manage first, hoping the patient is going to come through the door and give you the opportunity to then proceed with the subsequent management. Usually that's where the disconnection comes. Now, then again, going back to the Malaysian politics, I would say, then we are dividing them into three. The B40 is not going to come back. The B40 has got insurance claim issues, and if they need admission or whatsoever, they're going to make that last priority. And if they've not had that conversation with you, because you're the first one they're going to come to, probably through their panel card, right? The company covers, they come, and if you had that conversation, then the loop would have been smaller for them, or probably shorter. It could have been a big loop, but short time, or it could have been a small loop, less pain for a longer period of time. Whichever it is, my intention today was to connect these points. Since I have to stay connected to sarcopenia and osteoporosis, and I'm going to link it to Ayurveda, which will be the last slide. I hope it will make a difference hereafter, but let's look at this first. So as OOO, recognize the following, all Malaysian statistics. You would probably be able to go back home and see and look for those statistics in your geolocation and see how it affects your population. It's replicable, right, the format. Sarcopenia, OP Malaysia. OP means old people. Yeah, it's used even in journals and publications. So if you see the word OP and then they're referring to old people, although we in colloquial language call them warga emas or senior citizens and so forth, OP is known as old people. Who are old people? 60 and above. Obesity growing steady. doubled in Malaysia between 2016 to now, right? And then osteoporosis in Malaysia is still proudly understudied. But we're going somewhere in 2050. We're going really fast. We're doing good. Next slide, please. Hang on with your osteoporosis. Now, sarcopenia. This is probably not a very good copy, but I had provided the QR code. One of it has this, with the explanation and also with the article that is associated in reference to this diagram, you can call it. Yeah, this is a chart not to understand. I am 150% sure that all of you know osteoporosis at the back of your hand. Prof. Dr. Olha shared the details on how you risk it, how you categorize the risks, and then how you manage the medications. And then we also had introduction to the different classification. We have primary, secondary. Secondary is predisposed to different underlying chronic conditions, whereas primary is divided into two, which is postmenopausal, and you also have your senile type osteoporosis. So all the classifications aside, sarcopenia, you're talking about the mass and the functionality, right, and even the structure. So all this being compromised. Underlying conditions, so many. They are intertwined. There's never a straight line to a specific diagnosis that the pathophysiology of this condition is probably because of this, unless the chronic condition is an obvious diagnosis and they are undergoing treatment or management for the chronic condition, then you know the secondary osteoporosis or sarcopenia is thanks to that. So you would be able to manage that primary condition first before you move on to addressing the osteoporosis sarcopenia. Worst is to not attend to it. Let it wait. We finish the primary condition first, and somehow it will get to the management of the secondary condition. So in complementary medicine, what we receive is we receive them coming back again with the secondary condition, because the secondary condition is the one that is signaling them the most discomfort, right? It impairs them on daily functions to a point that it also affects their economic sustainability, their mental well-being, their ability to contribute to things that matters to them, like taking care of the kids or other commitments they have. So those things brings them to complementary medicine. And in their mind, one of the complementary medicine is massage, which is not. So, but they do go there because we have this branding, equity about wellness in Malaysia, which crosses between a thin line where on the left side you have got spas, which could get mixed up between beauty, and aesthetics. And then we've got the right side, which is heavy pharmaceutical influence for pain management. So they are usually swinging between these two, right? So at your end, this diagram should be the probably call card for your conversation. So ultimately, the context that I was trying to share, I am still trying to share and I'll continue sharing, is your conversation has to tweak, has to restructure a little bit, because the patients, okay, there's a right extreme and then there's a left extreme. So the left extreme is where we come from, where we are given the protocol to disease, diagnosis, treatment, right? So identifying the disease and then going back and forth, diagnosis, back to disease, to see whether it really works, whether this is what it is. Sometimes it even jumps to the third part where you try to diagnose a disease, and then you have a protocol, and then you go back to giving certain trial, protocols and see whether it works, and then they come back, it doesn't work, so I'm going to change that, instead of doing thorough diagnosis, because situations determine whether a thorough diagnosis is possible, whether the patient is going to, cooperate with you to spend the time and the money to be able to come up with a more thorough diagnosis. So those are all subjective factors. But a conversation which does not require a machine, now you can actually have your AI assistant if you wish to, right? Because there's no rule, black and white, that says that there will be a code of conduct breach if you were to use facilitated dialogues. There is no code of conduct yet, not in Malaysia, right? So if this becomes your communication card with them, the chances for them to go in that earlier loop will be lowered. This will significantly help the ones who are in the B40. And now with the current finance changes in our government, it will also affect M40 at large, because there are many M40s who are swinging between the borders of B40 and M40. So conventional medicine practitioners, physicians, your conversation is the one that is the deal breaker between them becoming the buyer of this concept called massage is complementary medicine. It is not. But at your point when the conversation is not thorough like this, asking them questions to rule out all this is just an example, a sample card which triggered me because it's applicable to today's topic. There are so many other sample cards that you can refer to, and probably even applicable to your demography where you serve. This probably is more Malaysian, Asian, Indian. So when we miss that conversation, you, by default, you and I make them a consumer or a loyal customer of what they perceive as complementary medicine or alternative solution to a doctor, which is the right path, which I was going to explain to you. The young ones who come under the SOOO earlier I showed you, we told you we're going somewhere really fast and really well, we're doing so good. Obesity, right? The age has gone down. Now it's children. It's no longer a story where we say, oh, it's West, where obesity is a crisis. No, it's here at home, right? These are your patients. This is your economic database. This is your business planning for your clinics. They are the ones who are going to keep coming back to your door, and they are the ones who are going to present you the different layers of the underlying chronic conditions. It's just that they're going to be younger. Earlier, you probably saw frailty, chronic non-communicable disease symptoms, 35, 30. Now you'll see it at 18. Obese. So if you remember the previous 3 presentations before this, each of it mentioned the physical activity and lifestyle. So even if that conversation doesn't happen at the conventional medicine front, so they will detour and go to places that they think is complementary medicine, and they finally come to us, complementary medicine, which is also part of what European Wellness does, right? We complement, we do not replace or discourage them from the existing conventional medicine protocols. We don't do that. It's not ethical. But what we do is, can you do this? Can you add this to your existing lifestyle? What is your lifestyle? Do we have the time to sit and to listen when they actually open up and say, actually my lifestyle is like this. I wake up at 5:30 and I go to bed at 10 o'clock, and I'm between work and children and work and children and work and children and work and children. When you just list your auditory senses, if you don't want to write it, it's fine. If you don't want to use your motor senses, but if you just listen to what they say, if you have that enough time, you realize how alarming that structure is. Most often this conversation doesn't happen in those cabins, right? It's prescription, if it's MC, then it's receipt, it's counter, it's collection, out. If it's parking, pay the parking, drive out. So that has brought them to complementary medicine. So when we started having those industrial expert meetings, then the ministry presented their different concerns on how the border is so vague, there's no definitive line, we need to educate the public and so on and so forth. WHO has done an extensive work, but they are an agency of convenience, right? They are an agency of convenience. So they would work with China, Korea and Japan for traditional Oriental medicine, and they will work with India and Sri Lanka for traditional Indian medicine. So do they have publications that is beyond massage? Does complementary medicine has to only be that which is nanotechnology and nanoparticle? No, it's beyond that. So when you are inclusive of that, and when you become that conventional medicine practitioner where you have that conversation with your patients, it is you alone who would be able to make that difference so that they don't go into that loop, right? So this is one of those cards that could probably help us to have a listening conversation with the patients, right? Let's go to the next slide. So DOSM projects a significant rise in percentage of citizens aged 65 and above. This is Malaysia. Yeah, we are moving towards very high senior citizen population, right? And this is double almost by 2040. If you do know your business share in the marketplace when it comes to caring for the senior citizen, your not necessarily geriatrics, managing frailty is not necessarily a geriatric component, but facilitation of, aging well is also a component, which is right between complementary medicine and conventional medicine. It is a very, the bandwidth is broad and it's getting broader because people are more informed and they're making the option. But this is applicable to the M40 and the T20, not to the B40. The B40 still need the conventional medicine doctors because they'll still choose you. Over AI, they will still trust you when you give them the prescription, and they will still, not only trust you, when it comes to a point of time when they want to replace you with the pharmacy, then they will take what you gave to the pharmacy, and the pharmacy will dispense it because we have many uncontrolled drugs, right, over the counter. They'll be able to consume it, and they'll manage the symptoms. So cycle. So imagine these senior citizens, they're going to double up, right? So they are your client margin. If at all you know your geolocation of your clinic, or wherever you are working and around it, do you know your geolocation? What is the senior citizen who walks through your door? What about your pediatric cases? Or do you have, is your business majorly, dependent on your panel affiliates? So the senior citizen thing is here to stay, which means if you are going to stay in business and service as a practicing doctor for the next 20 years, they are your market. You have to deal with them. They're going to come. So whatever little you do, whatever conversation you have with them, is going to affect our next 20 years. Next slide, please. The country officially reached aged nation status in 2021 already, so it's not news, yeah? So this is connected to today's topic where they're adding on, contributing, adding to the sweetness, cherry on the cake. So there's going to be lots of hip fractures. So hip fractures, they either go for the orthopedic cabin, or they come to you because they don't even know it's a hip fracture. Pain, 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 pain. It's only you. So in complementary medicine, when we interview and we speak to them, we realize all the spots that was missed, that this could have been picked up 12 months ago. Next slide, please. The risk of osteoporosis is doubled in postmenopausal women as compared to men. Any of you here publish articles diligently, consistently, or you co-author, or you collect data and then you submit to diligent writers, who don't like to collect data, but then they are good writers and then they publish articles. Any of you here? Any Malaysian? Anyone in Zoom? Yeah, check with Intan if anyone in Zoom can come live and we can discuss with them. Wrap it up in 5 minutes. None? The question is, any one of you often publish articles or contribute your data? You have a systematic way you're collecting data about your patients, anonymous, ethical, and then you pass the data, there's somebody processing it and publishing it because it's going to directly contribute to your practice and your fellow readers who would then be able to cite and make decisions based on your experience. None? Prof. Olha publishes lots of papers. So what is the purpose of this question? It's because when you do participate in such activities, there is a certain level of inquisition, and then the inquisition usually is either welcoming, people are very happy to come and share with you the great stories, or there is an inhibition, where there are certain flaws, but let's not talk about it, let's just talk about what works. So most often what you see out there in those glamorously referred citations, which tries to bridge between conventional medicine, complementary, and in my case, subject is Ayurveda, you would be able to see that there's just so much gap. So in Malaysia, coming back to this slide, we have a gap in studying diseases that affects Malaysian women. If you hadn't known, so yeah, today is news. Right? So the demography of Malaysian women, and then we've got different racial demography. Right? Because their food habit is different, right? Their cultural belief is different. Anthropologically as well, they're quite different. The Chinese, the Indian, the Malay, and the mix. And we have Iban, the Kadazans, the Duzuns. women category separately studying, so having an extensive research report is very low. But we are the largest patient who's going to come through your door for osteoporosis. Because menopause is by default. It's going to happen inevitably in our lives. It's not that, okay, we've got 7 women, 2 of them are not going to have menopause because they've got genetical supremacy. So they will be menstruating till the day they die, probably 85. No such case, right? So medically, it's just there. You are a classification follower, diligent, persistent. So menopause is a do or done case. It's just going to come, I just don't know when. It's like death. It's going to come, I don't know when. Before it comes, it's going to do all this damage. After it comes, it's going to double up the damage. And then in between, if it feels sorry for you, it will give you like 6 months break. Then it'll come back again. But we don't have this conversation in our GP clinics. Nor do we have it when we reviewed our undergraduate program reviewing of your MBBS and MD. No. Yeah? So by 2050, more than 50% of the world's hip fractures is projected to occur in, welcome home, Asia. Next slide, please. Local data, Malaysia. You can scan the QR code at your free time and read the articles that I picked this from. Right? Local data reveals 20% mortality rate after hip fracture. 20% mortality rate. If you didn't pick the beginning or the onset of that, osteoporosis, which directly pushes them based on Prof. Olha's slides, if you see with the diagnosis, flops them completely under type 2. Right? We're not talking about menopause. Let's say they have an underlying condition. Osteoporosis. But we didn't have the conversation with them, based on the card just now. To ask, what's your lifestyle like? Then when the person lives in a specific apartment and she walks up 5 floors most often, because her apartment is the 5th floor, the apartment block is no lift, no escalator. So you would know she's high risk. But that conversation never took place. Pain, okay, let's manage your pain. Right? Which also goes back to Dr. Klokol's slides when he mentioned his slides had the same solution. Professor Grigorieva had the same slide, same content, different looking slide. Same goes for Dr. Olha. The lifestyle part. The lifestyle part cannot be a general conversation. Please go for frequent walking. Please take care of your food. Don't eat too much rice. Prescription done. Please go, next patient. These are the people who end up in complementary medicine in my cabins. And then you see, okay, bring back all your reports. Then we also call our internal medicine people, and then they review the report. No, but this is here. Why wasn't this picked? So to a point, there's no point discussing. Why wasn't this picked. Let's pick it up now and move on. So that's what we've been doing. We pick and we move on. We pick and we move on. Right? So please have that conversation. Next slide. Although Malaysia is a tropical country, this is bravo. Malaysia is a tropical country. I'm exposed to sun all through the year, but we are vitamin D deficient people. You saw all the 3 professors before this. They had vitamin D in their presentation because it's an unavoidable element of preventing or managing osteoporosis and sarcopenia. Sarcopenia and osteoporosis are interrelated, not always, but yes. So with this assumption, even here, the statistics, thanks to the researchers who did the study, they actually, did the comparison, demographic comparison, like how our Muslim women live here in Malaysia compared to the Chinese and the Indians and the others who are mixed and different groups, minorities and all that. So when we see the clothings, how they wear clothes, they have their own diet, they've got their own festivities, so they've got their own holidays when they go and do what. Some holidays will require them to be exposed to the sun. Most of it, they opt to be indoors because, there is this, in complementary medicine, we see this as well a lot. Whitening, everybody wants to stay white. So they avoid the sun. But this is the case scenario. The risk predisposing factor is mundane and right in front of our eyes, but when we have the conversation with the patients, we don't have that. It's not included in the management decision, and it's not included in the treatment decision at all. So those were the days in Europe during winter. They will say, try to go and sunbath. You probably fly over to a Mediterranean place, go get some sun and come back, or whatsoever. When you're struggling with 6 months of winter with -10 to -40 ranging temperature, you can begin in Malaysia. Please go out in the sun in the morning. You can wear a hat, but at least let your hands and your legs burn. It's a conversation. For you, it's mundane. But for the patient, it's like, oh, doctor said that, I must do it. You will make a difference because we see the damage it has done when they come to us in the complementary cabin. So, full sleeve, cap, hoodie, and then they hide all the time. There's air condition. It's fine. It's their preference, their choice of life, but this has to be informed. Thank you. Next slide. Study revealed 82.7% of Chinese post-menopausal women in urban Malaysia had serum vitamin D deficiency. Chinese women in Malaysia, their dressing is not in comparison to the Muslim women in Malaysia. Indian women, mixed type of dressing. So our dressings, like for example, we do have certain areas of our skin exposed, so we are able to absorb the sunlight so that we will be able to make the different conversions that your desoxycholecalciferol takes place for the vitamin D to be released as an active compound in your blood and finally into absorption, and then it affects your calcium function onto your bone. So this chain has to happen by kissing the sun. But in our general medical practice, be it hospital, clinic kesihatan, GPs, or even specialist clinic, this conversation doesn't happen. If it is, it's a minority, and if you are one of the minority doctors, then yeah, thank you. Another multi-ethnic study found vitamin D hypovitaminosis, 26.7% Malay women, because Malay women, usually the clothings are long sleeve, long pants below the knee, usually cover the ankle. Some of them I've seen that they wear open sandals, some will wear covered. So if they are a hijab wearing lady, then it will be covered as well, the scalp, the hair, as well as the neck. So there's only this part of the face that is exposed, and if they are predominantly their lifestyle, if you ask them, what's your day-to-day life like Monday to Friday, Saturday to Sunday, voila, you'll find out. That itself will change your management decision. So they will be able to give you the information that you can then return back and tell them, these are the things that you have to change, or these are the things that you have to add on. And why? Next slide, please. 71.3% of Malay women and 12.2% of Chinese women had vitamin D deficiency, reflecting disparities among ethnic groups. See the difference? Next. After sustaining a fragile fracture, 80% of patients are still not diagnosed or treated for osteoporosis, leading to a high risk of subsequent fractures within the first 2 years after the initial fracture. This, if I can link back to a few other articles, publications, we've also seen it in oncology, where patients who have been diagnosed and confirmed with certain oncological condition, which makes it primary, and then the secondary osteoporosis is very high among them. But the management, when you see what they've done, especially if they've gone for the oncology treatment and they do come out stable, where they come to us to improve their lifestyle, their quality of life, and to regain their functions and all that, there we actually see that that conversation never took place. So a secondary osteoporosis was an outcome of negligence, I would say. If it's too heavy of a medical word, then probably you can subdue it with missed. We just missed it. Next slide. The prevalence of childhood overweight, obesity, and excess weight in Malaysia, bravo, doubled over 26 years, doubled. We go out to our wonderful, beautiful Kuala Lumpur, PJ. I'm from PJ. You just crossed 4 traffic lights. You would have passed 20 different food outlets. 4 traffic lights, 20 different food outlets, 90% of them processed sugar in different colors, shapes, sizes, and forms. So when you drive, you must tint your glasses so that your kids don't look out and point at it. Because then the whole journey will be nagging about that, you see. So we're doing well. We are approving them. We are franchising extensively. We are allowing all of them to come in. So this is the take home that we get. So if you don't have that conversation, who will? Next. Approximately 1/3 of community dwelling older adults in Klang Valley, old people, the OP earlier in SOOO, assessed to have sarcopenia. Older adults aged 60 years and above, and those with low dietary iron. So this is just to show that there is a study that links to that diagram that I had given you. When you have a conversation, please have that ruled out. Ask those questions and cross it out, you know. Or probably just tell them, are you doing this? If you're not doing that, can you do that? Next. 1/3 of community dwelling older adults in Klang Valley were assessed to have sarcopenia. 60 years and above. Yeah, I doubled this because this is directly linked to the old population that is on the rise. So in front of you, you have the old population on the rise. Behind you, catching up with you is a young population who's obese. So you can continue running. Right? At some point, all this will wear off. I will also become part of the old population at some point. And then I turn and embrace this one. The young, obese, underlying chronic condition patients who are running towards me. They're going to reach you. They're going to meet you at your place and your premise, and they're going to have you have a different conversation from today onwards. You're going to be that physician who's going to make a difference and reduce what is being missed, because the conversation can make the difference. It's not about all the other sci-fis. Next. So how do these scattered key points connect to complementary medicine Ayurveda? I shall wrap up. It does. Because Ayurveda advocates lifestyle. It requires, it requests, it begs for the patients to be able to confine to a certain type of food. One of the branch is also asana. Asana means, yoga. Not the yoga with the mat and, nice suits. What do you call that? Yoga suits and yoga mats. No. It's just that position wherever you are, in whatever form you are, and whatever clothes you're wearing. But even this is not conveyed. So when they come to us and we tell them that, you probably will start with the asanas after you've already seen the medical team, and then they will review the diagnosis you brought from the other doctors, and then we'll put you on a diet change, and then we will also manage your supplements. Added to that, we're going to request you to participate in the asana, which is one of the 8 limbs. Next slide, please. So if you'd see here, I've put it in English for you. So let's ignore moral codes, state of bliss, meditation, focus, concentration, sense of control, even observance. Even observance is a difficult thing to communicate, right? But those who come prepared, it's very easy to transit to that part, which is they are just watchful of their daily routine. They are watchful of what goes onto their plate. They even start color coding the meals that they take. It just cannot be predominantly white and brown. It has to have the purples and the yellows and the greens. When we come down and talk to them in their terms and language, they have lesser necessity to replace me with the AI or with a Google search. They call, I decided to do this, and then I decided to serve this, but then I'm in the midst of this. So that conversation is usually the game changer. Right? And then the next one is even breath work. Forget about breath work. Just breathe as you breathe. You walk up the stairs, you breathe fast, you pant, fine. You come down, you feel very relaxed, you feel dizzy, sit for a while, get up and walk. So we don't get into the technicalities of pranayama, because those things happen automatically when the patient comes ready to say, okay, you just give me a format and I'll follow, and you just tell me how many months I'm supposed to do it. And the return rate is very high, because they will come back and say, yeah, I felt this difference, I felt that difference. And most often the difference is because we talk. Yeah? Because decision usually is already made up in their skull. They want to get rid of the pain, they want to feel better, they're feeling ill, they've been going somewhere, it's not been helping, and they've been in that cycle looping around. Why not give this a try? So usually they walk through our door and they ask the very first thing, where our therapists at the reception counter, when they're attending to the clients and the patients, before the client becomes a patient, the transition is very different, both legally as well as practically. So when the patient asks, the client asks first questions, can I have massage? Very painful. I've been struggling this, but we cannot prescribe. If we are a registered practitioner, then we are not, massage is not a prescription. It's not even offered. That is relaxation, that is spa. So if you speak to your patients, and they do tell you I've been going for massage and all that, then the necessity, it's already a red flag for you to want to have that guided conversation, a little bit in depth, a little bit broad, and then you catch them and see whether you can convince them for thorough diagnosis, because there is an underlying condition. That which you see in front of you is optimally secondary. It's not something that you send them back with a painkiller and then see whether they come back. Yeah, so it's a spiral, yeah? It's a spiral because behind us, we have the young obese generation running towards us. In front, we are serving the frail, who are also increasing in number. At some point, we're going to stop and we're going to turn and receive them. What are we? Solution providers, right? So the format of being able to receive these two is here, because we have already done significant sum of allow cases slide through our fingers. So we don't need that anymore. Yeah, next slide. So this entire presentation today, you have had your dose from the first three speakers of the clinical part, the data, the diagnostics, the risk classification, and even the medications and different groupings, right? And then there is also this journal war where some of them say pharmaceutical publications, paid, but then they say not biased. Paid publication says that, okay. Osteoporosis promoting medications. How many of us have a list that when we discuss with a patient, we know whether the patient is on that medication? So they are automatically, due to medication, which is again secondary, is a risk to osteoporosis. So this is all conversation. This doesn't take us to the device yet or a diagnostic tool yet. So this is my only humble request, because the next upcoming presentations are all going to be clinical, conventional. It's going to equip you with more technical solutions. But I request your empathy. And this is not a personal opinion. This is what we see on ground. This is what we see when we review curriculums that needs the 30% review to incorporate the oncoming AI that is rapidly replacing us. Empathy is the only thing that's going to keep us. Is it okay for me to say in the market? Right? Thank you very much.